AMPOK is initiated. You know that this is the time of hormone receptor positive breast cancer. So for a change, I mean, all of us are bored listening to multiple talks about estrogen receptors and the CDK4/6 inhibitors and the various usages. Multiple meetings have been happening in the state and as well as in the country. So for a change, today we will be discussing on HER2 positive metastatic breast cancer. We all know that this about 10-15 years back or 15-20 years back, this was an old area where we didn't have much drugs, nothing was available. But the drug that changed the way in which we manage HER2 positive breast cancer was trastuzumab. Same like what is happening with the CDK4 inhibitors generics. Initially, only Roche had this product, and then subsequently, once it came off the patency, multiple companies came out with the products. So very good quality drugs with very cheap, very good quality drugs that at a very affordable price became available to the patient. Nowadays, I feel that almost a good percentage of our HER2 positive patients, at least if I can say from my practice, at least about 85% of patients who are HER2 positive are currently receiving some form of a trastuzumab. So we have actually evolved from the conventional HER2 positivity. We have better drugs, TDM1 positivity, multiple newer drugs are available. So how to sequence the drugs, that is an equally becoming a more and more challenge. So it all started with one drugs, and patients after progressing after first line, we have to start on second line drugs, and how to sequencing the anti-HER2 therapy is also becoming an important challenge in our day-to-day clinical practice. So today we will be discussing about this aspects. So first, Dr. Arun Vaidya will be presenting about will be presenting the doing the initial presentation. So he'll be discussing about the recent advances in the management of HER2 positive metastatic breast cancer. Arun Vaidya does not need any introduction to this audience. A close friend, very active member of AMPOK, working at Aston Medicity with nearly 15 years of experience in medical oncology. So I request Arun to take over the proceedings. Over to you, Doctor.
Thank you, Bhavan, for the introduction. So I'll share my screen first. Yeah, so I think it is in the it's visible and I'm audible.
Yes, you are audible.
Yeah, fine. So it's a full screen also. Yeah. Okay. So today we have two parts are there for this session. So first is my talk on the advances in HER2 positive metastatic breast cancer. So like Bhavan had told initially, there are a lot of molecules which are coming up, and I think the main issue is that the way we see HER2 positivity itself is changing. So I think that is the most dramatic thing which is happening. Rather than the drugs coming up, we are learning more and more about the biology of the disease and how the HER2 positive disease, how to defend them itself is changing. So I think that's also very relevant. And so we know that it is it comprises a large percentage of all breast cancers. Maybe HER2 positivity, as is shown here, is around 20%, but in our practice also maybe a little more, 20 to 25%. And definitely triple negativity we said a bit more. So this is the Western data, which was almost 65 of HR positive HER2 negative, maybe around 50 to 55 for us, and triple negative around 20 to 25%, and HER2 also around that range. And we all know that HER2 positive are aggressive diseases, and which is more likely to metastasize. So, so this was in the 1990s of the biology, many talks we have seen, how it evolved from Slamon studies, the initial how the response was there and how it was maintained. And maybe last 20 years, there has been a lot of trastuzumab has been holding the center stage. While in the recent years, newer molecules are coming up, and we will be reviewing them, which have focus on DDHD for today. So this is just to show that we all feel that we are doing justice by giving all our patients, or we are trying to cure our early breast cancer patients. With the generics coming in, most of our patients are receiving adjuvant trastuzumab. But still, as this slide shows, which is a good review from Medscape, I think all of you would have got the Medscape review slides. Such around 150 slides are there, which shows how the HER2 what are the new things. I am just focusing on the metastatic, but that's a very good slide which shows early, neoadjuvant, all these things coming up. So I think yesterday, today only received this, so I included some slides from that also. So this again shows that even in an adjuvant setting for early breast cancer, the 3-year cure rates has been say 75 to 80%, but they all dropped down. Even in the best trial settings, we have seen around 90% getting cured, like the BCIRG and all. But again, around 10 to 13% relapse over in the next 7 years. So relapses do happen in HER2 positive. Even now, up to 10 years also, they may come down, and the results may drop from the 90%, which we all imagine, from to 70 to 75%. So definitely there is a lot of things which are to be done in this subset of patients. So there is an unmet need. And what are the things which are there to meet this? So maybe chemotherapy like taxanes has been we all have been using as a backbone, and we know it is because of anthracyclines we can avoid. We have more better ways of delivery of taxanes here. Chemotherapy backbone is improving to say weekly chemotherapy taxanes are coming up. Which again may reduce cardiotoxicity and other side effect profile of the drugs also. Monoclonal antibodies, trastuzumab, pertuzumab, we all have used. Although pertuzumab use may not be high. The antibody drug conjugate, the ADCs, I think is really the main star in the HER2 realm today. TDM1 and TDXT. Again, TDM1 with the generic also coming up, all of us have used, and TK tyrosine inhibitors. Lapatinib is something which has slowly going out of fashion. Neratinib and tucatinib are there. There are some companies who have started giving neratinib also, but frankly, I have not used them. So there are things to be looked forward to. So again, just coming back to the metastatic breast cancer, in a first-time metastatic, what happens is that with each time that they relapse, all of us would have seen patients who live for 3 to 5 years. I think I had a 5-year plus was the longest period which I have seen in metastatic breast cancer. The patient had received TDM1 and she progressed on that for a long period after receiving it. And finally, we stopped because repeatedly PETs were remaining negative, but then it came back with a vengeance. So up to 5 years plus also we have patients who have survived, but average it is around 2 to 3 years. And the number of patients who receive therapy also drops down, mainly because of maybe tolerance. So this is from the Western data, but definitely finance is not the issue there. So there are various other reasons. The patient's fitness may come down, the organ compromise may happen. We know patients can have big liver mets, compromising liver function. So that may be a reason in a second line setting. So like this, around 22% may not receive from first line to second line, and from second line to third line, again, 35% may not receive treatment. So that is what happens. So sequencing, that is why it is very important. We have to use the best drug first, and how to preserve the drugs for the next lines of treatment is also a question. So up to 2022, so we had Perjeta or pertuzumab was one area, and TDM1 was the. So I will just review some of the data because many of you may know about this, but I think we have postgraduates also here. So we have in 2012. So that is when the Cleopatra and Emilia were all reported, 2012 and 2013, around 10 years back, in which in a first-line therapy, TH was the comparative arm and THP was the with pertuzumab was the other arm. So in that group, the prior therapy was predominantly trastuzumab, while no one had received other things. So that was pertuzumab was a new drug which was tried there. So which showed that around the PFS was improved by around 6.3 months, and overall survival was around 16.3. So definitely, it showed that adding a new drug is good, and the treatment-related adverse events were there, which was expected, and grade 3 events were also a bit higher in the THP versus TH. Then again, Emilia, that again around 1,000 patients were there, in which TDM1 was compared against lapatinib and capecitabine. I feel this may not be an ideal comparator regimen, but still that is how the trial was designed. because many had received trastuzumab. So maybe they tried to use a different thing. That's the trial is said maybe 10 to 15 years back. So at that time, the biology was not well looked like we know it now. So, again, definitely TDM1 had an upper hand there. And again, the PFS was a 3.2 months improvement. Even with such an active moiety, it didn't show anything great. There was a statistically significant improvement was there, but the absolute terms, it was just 3.2 months improvement only was there for TDM. So median PFS drops by half, moving from first line to second line. So like we saw before, many patients may not receive. The PFS definitely comes down later. So 18.5, then it comes down to 9.6. So if we give TDM1 after we give pertuzumab, so that is the main thing which is highlighted here. So I'm sure that as clinicians, many of us were not very keen on using pertuzumab because we always had to give it along with trastuzumab, and somehow the financially, the logistics is also a major issue. So for us giving pertuzumab with trastuzumab in an upfront setting was a financially very challenging one also. So, because of this, many of us were not giving a TDM1, giving pertuzumab plus trastuzumab combination in the metastatic setting. So, if we look here, that may be of importance because pertuzumab can make the cells resistant to the action of TDM1. Again, what happens is that the HER2 the expression comes down. So, like is shown in the pathology slides here, the HER2 expression comes down. So that may be the reason why we are seeing a less efficacy when we are giving TDM in a later setting. So Cleopatra Emilia were conducted simultaneously, as I told before, around 2020 it was reported. And after that, we had some real-world studies also, in which again this TDM1 after pertuzumab was looked at. So this was the Italian study, which evaluated second-line TDM1. So which again showed that a significantly worse median PFS. If we look here also in the randomized control type, in the pertuzumab naive arm, they had a 9.6 months improvement was there. So it again shows that the biology is correct. And biologically there is a reduced expression by giving pertuzumab. So we can give trastuzumab only and reserve TDM1 later. So that is one thing which is evident from all this analysis here. And now, so in 2023, what are we looking at? We are looking at molecular antibodies targeting HER2, PA3 signaling pathway, CDK4/6 inhibitors, immunotherapy-based approach. All these things are there. So again, in a short span of time, from 2019 to 2 years or that time onwards, around 8 anti-HER2 drugs are currently authorized, and 4 were approved in a frame of single year. So that was just before the COVID when TDM1, the TKS, neratinib, tucatinib, and margetuximab all got FDA approval. So definitely it was an exciting time and just review. And I think today's focus is definitely going to be TDM1. So TDM1 is a different molecule because there are many things which are different from, TDXT. It is different from TDM1 because the payload is a topoisomerase 1 inhibitor and the drug to antibody ratio is around 8:1. And it has got a tumor selective cleavable linker. And also, I think the main thing is an evidence of a bystander anti-tumor effect. So this bystander anti-tumor effect is, if you ask me, I think is the one thing which makes the TDXT much more efficacious than TDM1. So what is this bystander thing? So if you have this antibody drug conjugate, it localizes to the tumor, we know, the HER2, and it binds the target receptor. After that, it is internalized and it is taken into the lysosomes where it is degraded, and the ADC is degraded within the lysosomes. And after that, it can come out and it can cause a cancer cell death because it is inside the cell. It leads to cell killing. But one important thing is that the TDXT, being a membrane permeable thing, can come out of the cell and can be taken up by the neighboring cells also. While if it is a membrane impermeable drug, it remains within the cell. So this is the main reason why the TDM1 is not able to come out, and the bystander effect, which is very important for TDXT, and which I think gives it makes it much more superior also in a pharmacological way. So bystander effect is there, which helps in kill of the neighboring cancer cells also. But it has got problems like we'll come to later. So coming to the various, we have various destinies there. So starting from the Destiny 1, which was a phase 2 trial, phase 2 study of TDXT, which had a pharmacokinetic part also. So they tried it in prior TDM1 patients, and pre-treated and stable brain mets were also allowed in this group. And they were in a PK stage, part 1, part 2. I'm not going to the intricacies of this. And various doses were there, and 5.4 mg per kg was a recommended dose which was given, which was stored. So in the Destiny V01 in NEJM 2020, which showed that the PFS was around 16.4 months. So just imagine this in a median of 6 lines of therapy were given in this group. And there was a response rate of 61%, which I think is quite unexpected for any drug in such extensively treated patients. And the clinical benefit rate of more than 6 months was in around 76%, and the median duration of response was around 15 months, and the drug had it effect in, within 1.6 months also. So this gave the first approval for the drug by FDA in more than second line, more than or equal to second line in 2019 December. So this was the phase 2. And based on that, accident approval was also given. So now this is a here they tried the HER2 positive. So the next 2 trials are basically in a HER2 positive setting only, because here we are comparing the drug against trastuzumab or lenvatinib cabozantinib. So we have to reach to Destiny 4 to come to the HER2 low population. Other than that, here and all, it is all HER2 enriched, at HER2 3+ or 2++ fish only are taken here. So previously treated TDM1. So this is from the SABCS, as recently 2 months back. This was presented. So which showed that the TDXT had around 62. The primary endpoint was PFS by the BACR, which showed that the PFS was 62.3% versus 27.2 at 12 months, and it was sustained at 24 months. Also, it was 42 versus 13.9%. And the median PFS was 17.8 versus 7 months. So highly statistically significant, which we rarely see. And the key secondary endpoint was an overall survival, which was 39.2 versus 26.5. Again, at 1 year, it was 89.4, which was maintained at the second year also 65.9. So there was around 10 to around the 20% improvement in the overall survival, and the median was also significantly, there was a change was there of 26.5 and 39.8. So in the TPC arm, around large percentage received a new systemic anti-cancer treatment, while among them at least a quarter received TDXT in a post-trial setting also. So in the Destiny Breast 2, TDXT demonstrated a statistically significant and clinically meaningful improvement in PFS and OS, and reduced the risk of progression or death, and also and the safety profile was also consistent. So safety part I will be coming to later. ILD is a major issue here, and the reason will be shown later, and it was around 10.4%. And again, I think grade 5 events. So compared to Destiny 1, compared to Destiny Breast 1, the amount of ILD events were actually less. So maybe once there was more people come to know more about the side effect and they knew how to manage, we could reduce the grade 5 events. Grade 5. So this is the Destiny 3, which had patients who had prior to pertuzumab also, in which TDXT was compared with the TDM1, And the primary endpoint was PFS and overall survival, and the secondary were the other factors as is shown here. And brain mets, I think brain mets is an area on its own. And here they were in HER2 positive, definitely it is important. And they were measured at CT or MRI, and it was monitored throughout the study. And we all know that the progression in the brain is a major issue for HER2 positive disease. And we have few options once they have the brain positive, they develop brain mets. And the baseline character, I think, very, very important here, that Asian countries, around 60% were from Asia, which is very rare if we look at any large randomized control trials. And almost the Asian region and the race were all around 58% from Asia. And the history of brain mets was around 24% in TDXT, and TDM it was around 20%. And then definitely the number of patients with visceral disease was higher, and but it was comparable in both arms. So approximately 60% had received prior pertuzumab, and like we have seen before, anybody receiving pertuzumab, actually the benefit of the further lines of drugs are going to be less, and as HER2 expression is going to be less, definitely TDM and efficacy is going to be reduced. So that may be the reason why TDM fared so poorly in this trial. And almost everyone, now 99.6 had received trastuzumab, as is expected. And the number of the lines of therapy were 2, which were it was around from 0 to 16, and I think at least 20% received in more than third line of setting. So again, they were an extensively pretreated group. And I think like we have seen before, we have seen much separation of the curves here also. And the 12 months PFS rates were dramatically doubled, 34 in TDM1 by 75.8 in the TDXT arm. So again, shows how the drug is an entirely different drug compared to TDM1. And again, they are stratified based on the hormone receptor status, visceral disease, prior lines of therapy, history of brain mets. Whatever characteristic you look at, there was a clear winner in TDXT here. So this is an updated one, which again shows that the median PFS was 28.8 and 6.8. I think the statistic is 0.000001. So that's significance. In the investigator assessment also, we are seeing that much high number of zeros here after the dot. So shows it is highly efficacious. Overall survival, we know it may again come together because they may all receive TDX, like 35% received TDX, sorry, around 18% received TDXT. So that is the reason OS is around 94, at 2 years it is around 77. Overall survival by subgroups also, when they analyzed, again, all were favoring TDXT. I think it was nowhere near, so there is no point in going into details of this. So across the subgroups, all were favoring TDXT. So with and without brain mets. So brain mets again is a concern because they were extensively treated patients, and we know as a sanctuary site, CNS is a failure, site of failure. So at baseline, if they had brain mets, again the PFS rates were 3 TDM1 versus 15 in TDXT. With no brain mets as baseline, it was 7.1 in TDM1, while it is not at there in the TDXT arm. And the 12 months PFS rate is as high as 76%. I think it is almost same. Here also we are seeing brain mets at baseline 72, while even with no brain mets, it's around 76.5. So it may not make any major change. So interstitial lung disease, I think, is a major thing which we have to worry when we look at TDXT. So grade 1 is in interstitial lung disease in TDXT in around 10.1, and any grade is seen in 15.2, while in TDM1 it is a rarity 3.1. So there were overall incidence was 0.8, and there were no adjudicated regulated grade 4 or grade 5, let's say. So what is the possible mechanism? What it's elegantly described in this Medscape is that there's a HER2-dependent uptake of the antibody drug conjugate. HER2 receptors are seen in the alveolar macrophage alveolus also. So HER2-independent uptake happens in the intra-alveolar immune cells. And like we saw before, the drugs, once it is metabolized, can leach out also. And the bystander killing by the free payload released from the target cancer cells can happen, and it can circulate in the bloodstream. So because of this, there is an increased concentration there in the alveolar macrophages, which leads to the ILD. So maybe it is a class effect of these drugs that they have this of ILD preponderance is more here. So I think again we have to pick up early, like when you're picking up at the grade 2, that is where the predominantly it is there. And if you can prevent it to grade 3, then we would be definitely able to treat it in a better way. I think TKs we have seen, particularly afatinib and all, we are seeing this more commonly now. So with steroids and all, we should be able to manage in the future. So, so this is ESMO 2022 update. It showed that overall health status and QOL was maintained with TDXT. So this is the quality of life which shows it was maintained across most of the subsets. So again, the Destiny breast 3, the conclusion is that it is clinically significant. I'm not going to others. Yeah,
there's some background.
Repeating the whole things, I think is very clear. Very good improvement in almost 3 to 4 times improvement in PFS, which is a very good improvement in the overall response rate also. And we have to be careful of the ILD. So now I think this is one thing which all of us are interested by. Shanu Modi, I think she was a PA in most of the Destiny trials. So Shanu Modi, so this again from Medscape, which they have described about what is HER2 low breast cancer and how we can optimize that. So this is again about how we are re-looking at HER2 now. So we are all aware of what is HER2 positivity at 3+. I'm not going to that. So HER2 positive and in HER2 negative, there is a HER2 0 and HER2 1 and HER2 2+. So in again HER2 2+, we know there is a fish can be equivocal, it can cause amplification, and but 1+ and 0 are the really HER2 different things. So here, if we look at here, it is HER2 low, HER2 positive can be around 15%. HER2 negative can be around 30 to 40%, while HER2 low is around 45 to 55%. And in the a large subset of this is actually hormone receptor positive also. So hormone receptor positive, HER2 low breast cancer is one area where a lot of focus is happening here. And gene expression profiling has been done in breast cancers, and that they also show that there's a marginal difference in gene expression between HER2 0 and HER2 low tumors. Triple negative are mostly basal-like, and hormone receptor positive are mostly luminal, and slightly more basal-like are seen in HR receptor positive HER2 0 group. So there is some there is a difference in the gene expression profile which may be contributing to the differences in the outcomes also. And so this is again about the prognostic significance. A lot of trials, a large number of patients have evaluated these and shown that there is no OS difference in HER2 low versus HER2 0 breast cancer, regardless of hormone receptor expression. So hormone receptors, how much HER2 is expressed, all these are going to be very significant when we think of using these drugs in our near future. Because once these drugs become available, which I think in a few months, they're going to get them. And this data is really large number data also. So again, interestingly, they have reanalyzed NSABP 31, that is 2008. We all know NSABP, how it showed the importance. And they found that almost 10% of samples were actually non-amplified. So again, the pathology, how much important it is, like the discordance rate between experienced pathologists is in HER2 is to the tune of 10 to 20%. So that's a challenge. So maybe if we go for, when we are to interpret, just imagine for HER2 3+, if it can be that much, how much it can be for HER2 0 and HER2 1. And as I told before, HER2 0 and HER2 1 may make a major change for the treatment in our near future. So our pathologist has to be really sharp if they have to pick out the real HER2 0. So that is one area of focus. So this is NSABP. So this was NSABP 47, which was reported in 2020, which showed in the HER2 low risk, there is not much of a benefit. So now coming to the HER2 low. So this was last year FDA approval for HER2 low subset. So HER2 low, as we know, we don't have, there is no trastuzumab, no question of any HER2, no question of any TDM. So we have to compare in this group TDXT versus treatment of physician choice. And again, they were multiple extensively pretreated patients. And if they're hormone receptor positive, they should be considered endocrine refractory also. So this was interesting here, and which showed that the PFS in hormone receptor positive and in all patients. In hormone receptor positive, it was again significant, 5.4 versus 10.1 months. While in all patients like hormone receptor positive and negative, again, it was significant, I think almost similar, 5 and 9.9 months. So not as big difference as we saw in the HER2 enriched group, but definitely it is a valid drug, or that's why the FDA also approved it. So many of them had received, as Boban had told, CDK4 inhibitors. So it's all becoming saved. It's all interplaying now. So whether they received prior CDK is important here, and the race region. Despite all these things, I think there is evidently a favorable profile for the TDXT here. And overall survival again was 17.5 and 23.9. So there was a 6 months improvement in overall survival, almost similar to what we saw in the PFS. So now we are so 1, 2, 3, and 4 here. So definitely neoadjuvant 5 is there. First line metastatic, there is 0.7 is there. And in second line metastatic, there are third line metastatic is there, and Destiny 6 is there. So a lot of other things where it is again in HER2 low, HER2 positive, combinations, monotherapy. So it is going to be a very complicated area. So I'm not going to explaining all these things because I think we can review that, and these are all trials and which we are all expecting results in the next coming years. So it is not just HER2, the TDXT here. A lot of other drugs are there. And if you just review those things, the mechanisms are all different, and there are many other pathways which are correlating with HER2, which has been described. So something may come up from all these things. So now coming back to some drugs which we have heard for the last couple of years. One is tucatinib. So tucatinib was again in 2020. TLGMT criteria who had a prior disease. So here the main thing is that we are looking at the brain mets. We know all the other trastuzumab containing IV things may not penetrate. So tucatinib and neratinib, the brain were the main thing which they looked here. And what it showed was that in HER2 climb, the median PFS was again around 3 months improvement was there. Overall survival was also improved to that around 3 to 4 months. While it has got its own set of side effects also. So that is one thing which is possible. And brain mets is one area where tucatinib has shown to have a benefit. Not going to that. And then neratinib is coming next. And neratinib again 2020 was approval. Was compared against lapatinib, and it again showed around 2 months improvement in both PFS and OS. And margetuximab, again, the initial time 2019 improved, and the PFS improvement was just 1 month. I think again it was extensively treated population with a new mechanism of drug, and it has got a unique side effect of neutropenia. So Sophia trial was against again for this. So if you look now, 2023, the current treatment algorithm, first line options, we definitely have pertuzumab, trastuzumab dosi, pertuzumab, trastuzumab pacli. But again, the word of caution of using pertuzumab in a first line setting, because we know second line options may be limited because of that. If TDXT is available, yes, we can. And second line option, TDXT, TDM1 are there. Third line plus, we have again TDXT there with the TKS and margetuximab, which I told before. And ESMO also, these guidelines, they have changed. And if available, these drugs have all come into the major society guidelines also. Even NCCN also incorporate newer drugs from second line, it is there, and from third line and beyond also it is there. So all the guidelines societies are changing their guidelines to incorporate these drugs. So I think mainly between first line THP and second line TDM treatment, we know that the median PFS drops numerically. So more effective treatment options that are needed in second line. And the current treatment paradigm includes THP followed by TDXT after progression with multiple third line options. While in third line, it's still not clear, and we are definitely seeing more and more people surviving till that time now. And the main other focus is about HER2 low. The Destiny breast 04 has demonstrated very clearly that TDXC has the potential to improve the treatment outcomes in this subset of patients. That's all from my side. Thank you.
Thank you, Arun. Thank you, Arun, for taking up the history and evolution of anti-HER2 therapy. So right from our trastuzumab days to TDXT, TDM1, and TDXT days. So from all the data which has been discussed, I feel like the future of the destiny of anti-HER2 therapy is going to be very good, because many newer molecules are coming up. Many newer molecules, it has shown to be very, very effective in second line settings. Now it's in first line setting, and now the trials are coming up in early stage disease, whether it is in the neoadjuvant setting or in the adjuvant setting. I'm sure that very soon the data will be coming. One important thing is that about the brain metastasis thing. So we have been curing, that's a sanctuary. Brain has been acting as a sanctuary site whenever we are treating patients with anti-HER2 therapy. So last week we also had a patient. She had a large locally advanced breast cancer. It was HER2 positive, where she had a very excellent response. So in fact, almost a complete response to chemotherapy. So then she underwent surgery. There was no residual disease in her breast. We completed the trastuzumab, radiation, everything. And unfortunately, last week she came with headache, and then 2 days back, when I did the MRI scan, she has got brain metastasis. So brain metastasis is a serious issue. We have been able to cure the disease in other parts, but brain is the serious issue when we are using the conventional trastuzumab or the first line, or I would call as the first generation anti-HER2 therapy. With the newer drugs, the second generation, third generation, or the newer anti-HER2 therapy, we have been able to effectively target the brain in a better way. But then, unfortunately, the cost is beyond the reach of a good number of patients. So, except for cost, when you're discussing the theory part, it looks very, very promising. So I hope that same way trastuzumab became available for a large number of patients with the generics. Hopefully in the future, TDXD and other TDM1, all the molecules will be available to our patients also. Any questions, comments from the delegates? So if there are no further points to be discussed, we'll go to the panel discussion. We spoke about the theory part, but then when it comes to the practical part, we might be treating patients in a different way. So the data, we know that our very few patients from our population will be enrolled into the clinical trials. Most of the patients are from Western population, where they have easily access to a large number of clinical trials. So invariably, all the newer drugs, patients will be on some form of a clinical trial. So a good number of patients will be able to get that thing. But in our population, we know that it's a totally different situation. Our access to clinical trials are very limited. Very few number of patients will be able to afford all these newer molecules which have been discussed. So what's our practically, how are we treating a metastatic breast cancer which is HER2 positive? So those points will be discussed by Dr. Arun Chandrasekhar. So I request Dr. Arun to take over the proceedings. Arun Vaidya, can you just close your slide so that?
Yeah, that's what I'm trying to do. No, I'm stuck somewhere. Can they stop sharing from your side? Means Ashim can do that. Not able to.
Hashim?
Hello?
Close help Arun Vaidya.
Stuck.
One second.
Leave Arun sir. Leave and then rejoin.
Just control.
Okay, close it.
Okay, fine. Yeah.
Okay. Thanks. So the next is the panel discussion. The panel members I request to join Nikhil Haridas, Dr. Rona, Dr. Matthew Jose, Dr. Prashant Parameshwaran, and Dr. Mithun Chako.
Okay. Thank you, Bhavan sir, for the opportunity. I think Dr. Arun has completed all the theory part, explained it in detail what exactly we have the data, but we'll be discussing, as sir said, what we are using in practice per se. What are the main things that issues that we face practically, and how we've sequenced this therapy in HER2 positive metastatic breast cancer. So I think everyone is here, Dr. Nikhil, Dr. Rona, Dr. Matthew, Dr. Prashant, and Dr. Mithun. Oh, okay, so we'll start out. Okay, so I won't be looking too much into the theory part already. Dr. Warrior has, told it in proper therapy and proper sequences. So first, what we'll be discussing is what to give a patient with HER2 positive breast cancer, whether you need to,
I
test.
don't.
Yeah.
Dr. Sanjo is also in the panel. I forgot to add him in this list.
Okay.
So Dr. Sanjo is also there in the panel.
The old list had
Sanjo, you're
Dr.
there?
Yeah, Dr. Punraj is also there, sir.
Yeah. Punraj is also.
Okay, so Dr. Sanjo and Dr.
Punraj will be there.
So 7 people.
Yeah, 7
Okay.
people.
Fine, sir. Okay. So welcome everyone anyway. And yeah, so we'll be discussing about the HER2 testing, whether we need to do rebiopsies, how to manage brain metastasis, and also targeting, and treatment sequencing in the era where you have all these new drugs. So this is the patient. In short, it was a 55-year-old postmenopausal woman who went for a routine checkup, and on examination, there was this left breast mass with axillary lymphadenopathy. So it's a left breast mass, and the patient had elevated alkaline phosphatase, and your imaging showed a 2-centimeter left breast lesion with suspicious axillary lymph nodes. So the biopsy of the breast was done, and the axillary nodes as well, and it was suggestive of an infiltrative ductal carcinoma, which was HER2 positive and hormone negative. Brain MRI was negative, but on the PET scan, there were multiple bony lesions, multiple lung lesions, and here they confirmed, they did a biopsy from the metastatic site as well, and that was suggestive of HER2 positivity there. And the patient's performance status was excellent. So I'll start off with Dr. Nikhil with this patient with stage 4 HER2 positive breast cancer. What would be your first recommendation in this?
Yeah, as right now, as discussed, theoretically, there is a tendency maybe to even consider a HER2 positive patient to consider TDX as per the data presented. But currently, I think in a practical scenario, most of my patients may not be able to afford that. They'll be able to afford the generic trastuzumab. If they can afford the pertuzumab, particularly right now, we are having the subcutaneous formulation which is coming fixed. We can consider based on the Cleopatra's data, we can add a taxane plus trastuzumab, pertuzumab. That actually taxane plus trastuzumab remains my go-to for de novo metastatic, HER2 positive breast cancer.
Okay. So
of course,
money no.
If it is not de novo, there are other consideration which comes into play.
Okay, so no, there's no money. It's not a concern. If you had TDX, would you use it upfront without prior exposure to anything? I think the FDA approval is not out yet, right? For TDX1 upfront.
No. Second line.
Second line.
Post
so,
this thing, taxane and this thing.
Okay.
So Cleopatra protocol, if money is not the issue, the patient would be on a taxane plus pertuzumab, trastuzumab.
Okay. Any difference, Dr. Rona?
No. If there is no logistic issues, dual anti-HER2 with a taxane is the standard of care, and I'll choose that.
Okay.
So I'll prefer to use FESCO.
Okay. For the convenience and okay. I think the cost also turns out to be better. No,
Yes.
just an additional question, like in this, they've done a biopsy from the metastatic site as well. Do you routinely practice that, or is the primary breast site enough? This is de novo metastatic.
Yeah, routinely we don't do biopsy from the metastatic site, and we'll do only the breast biopsy.
Okay. Yeah, I found that strange, and there's some data where they say there can be a discordance between the metastatic.
Yeah, that is there, but
I think nobody.
even in same tumor itself, there can be heterogeneity.
Correct. And Dr. Matthew, any other opinion? Cleopatra itself or different?
As finance are not a constraint, then definitely dual HER2 blockade with taxane would be my choice.
Okay, I think rest of the panelists also would suggest the same, unless there's any other objection. So this all data comes from your Cleopatra trial, which was a 17 months survival benefit. That's like 1.5 years, and PFS 6 months benefit as well. If you're considering TDM1 in the upfront setting, there is data to say that it does not improve, outcomes. So using TDM1 upfront into the rare case where you have some major toxicity to the other drugs, there is no benefit in using that in this antibody drug conjugate in the first line setting. So this patient received the Cleopatra protocol, and after 6 months, paclitaxel was discontinued due to worsening neuropathy. Trastuzumab and pertuzumab were continued, and after imaging at 3 months, there was no FTG activity, complete response, and denosumab was started then to reduce skeletal-related events. So the next question to Dr. Prashant, there's some things here, like one question, like what percentage of your patients get this dual therapy? Like, do all the patients, this is practical, like how many are affordable for the Cleopatra protocol?
In my practice, 10%.
10%. One more question, because the previous one, they've given paclitaxel for 6 months. Routinely, do you prefer DOSI or Pacli, and how many cycles?
Normally, I'm giving more of docetaxel, 6 cycles of dosi.
6 cycles, yeah. So I think the trial also said at least 6 cycles. They didn't say you need to stop, but I think everyone practices 6 cycles because of toxicity. Dr. Mithun, your percentage in Thrissur, how many percentage in MBR?
My percentage will be around 5%.
5%.
Very less patients get, and I usually prefer docetaxel instead of paclitaxel.
Docetaxel, okay. Dr. Sanjo, down in more towards the richer parts of Kerala, how many percentage can take in your dual HER2 therapy?
No, I'm from actually Idukki district, so even less than that, maybe around 5% only.
5%, and I think this is 5%. Dr. Punraj will give us the real, okay.
Yes, I am in poor district of Palakkad, so I didn't use any patient till now in pertuzumab, sir. I used only trastuzumab plus taxanes, preferably docetaxel, sir.
Yeah, so I think it depends on where you're practicing and what kind of patients we see. So I think if we ask, maybe Lakeshore numbers might be little on the higher side per se, but or some patients who are from the rich parts. So yeah, I think the average would be around less than 10%, means among the patients who actually can afford it. And cycles wise, I think all of us use around 6 cycles. Dr. Punraj, same. You prefer DOSI or Pacli?
Yeah, sir. DOSI only, sir. DOSI only. 6 cycles.
Okay. And again, back to Nikhil. Subcutaneous, you said you wanted to use Pesgo. So, like, are there patients, have you used Pesgo on patients, maybe not in the metastatic, even in the curative setting?
One patient, exactly one patient.
One patient. This is metastatic or in the curative setting?
No. In the neoadjuvant setting.
Neoadjuvant setting. So I think it's like, yeah, you get a good package for the 4-5 injections for 5 lakhs kind of package. Anyone else with experience with Pesgo in the metastatic setting? Dr. Rona or Dr. Matthew? Dr.
Yeah,
Prashant?
I've used in, I have used in metastatic setting.
For all affording.
Yeah.
Okay, Dr. Matthew, you can complete, then we come to Dr.
I've used metastatic setting, continuing. Only problem is she's keep on getting severe diarrhea in between. Otherwise, it's very easy to use. Within 10 minutes, you can finish off and you can send the patient. But diarrhea, I don't know. She's getting so much of diarrhea. Initially, I thought of it's because of combination while giving chemotherapy. It was initial 6 cycles also she had diarrhea, but after stopping docetaxel again she had diarrhea. But the frequency is coming down, but still she has diarrhea.
Okay. And how long have you been taking this patient? Like since how many months?
Now it's since last 6 months. 6 months now.
Okay.
On Fesco.
It's good. Yeah, things make it much more convenient. Dr. Rona, yes, you had a patient. I think something to share.
Yeah. Yes. For all patients, now I am using Fesco upfront. We have quite number of patients, and my experience with Fesco is very good. which is very convenient, and there is no need of all this pre-medication and all.
Okay.
I haven't encountered any of these kind of side effects. And
Okay.
now most of our patients who were on this IV trastuzumab and pertuzumab, they're all changed to Fesco, and they're all
Okay.
doing well.
And local reactions, like I think that's the only thing.
No,
more common than that.
initially we were very much worried about the local reaction and all, but fortunately none of our patients, I mean, they have immediate local reaction, but that is not significant, not
Okay.
very difficult for patient.
And do you use any?
From their part, actually,
yeah.
they usually teach you, the nurses over there. They'll give a proper class how to give that Fesco properly. And after that class, I don't think all of them are now very good in giving that.
And I thought some of them actually use a local
It's
agent
also
also,
there.
like I think the dilutional agent, sorry, as in some kind of warm compresses also in some cases, but I think that's not recommended by the company to reduce the amount of pain which is there. But yeah, I think it's going to make a major change. The cost is also quite attractive, cheaper than the IV formulation. So more persons are shifting towards it. Okay. Subcutaneous trans-2 plus pertuzumab is as good as your this thing, as good as your IV injection as well. So moving back to the case, this patient, as we said, had complete response to your Cleopatra protocol. Here, denosumab was started a little late. Normally, we've started upfront with bone meds. But anyway, later, after 18 months, she developed dry cough, progressive bone disease, and multiple new liver nodules. So progressive disease in February 2022 after 18 months progression. So next line of therapy, Dr. Prashant, this is to you. So they've received pertuzumab and trastuzumab and taxane. What is your next go-to drug? Again, cost no constraint. Dr. Prashant, I think you're not here. I'll just move on then. Dr. Mithun, your option.
Yeah, with the present data, if there is no cost constraints, then I think it would be better to go with TDXD. That would be one option I would prefer.
Okay, and if I forgot to mention, TDXT is not available in India. So if that is the case, without import,
TDM1.
TDM1 is the thing, So if available, TDX, and if not available, TDM1. Anyone else? The Dr. Sanjo, any difference of opinion?
Yeah, I mean, if TDXD is not available, then TDM1. Otherwise, I would go for TDXD. Currently, I have 2 patients on trastuzumab and pertuzumab. So one had progressed. So that patient we had put her on TDM1.
Okay.
So if TDXD is available, then TDXD. If cost is not a constraint,
I'll make it a little more challenging. Suppose this patient progressed only in the brain. Which drug would you choose second line?
I think the TDXD.
TDXD, And again, TDXD not available. Would you think of lepatinib, capecitabine because of blood brain, or TDM1?
Difficult.
Because the crossing of TDM1 is, they say, a little questionable. But the third option is you irradiate the brain and then give TDM1.
Maybe I'll go for irradiation of the brain and then
put I think that breaking the blood-brain barrier would be better in this case. And Dr. Punraj, same question. It's if you let's look at the cost restraint. If the patient is not affordable for TDM1 and TDX, which is your drug that you use?
Yeah, trastuzumab lapatinib is still not a bad choice actually, because especially because TDM1 you can see that response may be good, but tolerance is not that great actually. Even my experience also not that good actually. So I will give the both options actually. If the patients have brain metastasis, I may consider for trastuzumab plus lapatinib. Otherwise, systemic metastasis, I will consider about TDM1.
But would you continue trastuzumab even after progression? That's a
yes,
question.
sir. Yes, sir. Because still can be continued actually beyond progression. Also, we can continue the trastuzumab plus because we are changing another. We are adding one more molecule. Lapatinib is the dual anti-HER2 therapy. Still, data is there actually, so we can consider that trastuzumab plus lapatinib.
Okay. Well, and about lepatinib plus capecitabine, would you consider that below trastuzumab lapatinib, or just as in would not consider at all?
Yeah, that can be considered actually, but I can keep it as a still reserve actually. Yeah, next line.
Okay.
Yeah.
Dr. Nikhil?
Because I
patient-
have 2-3 patients I put on trastuzumab lapatinib, they did well actually. I don't know, this is my personal experience actually. I have 3 patients with a dual anti-HER2 therapy, they did well with at most 1.5 to 2 years like that actually. So that's why I am preferring that dual anti-HER2.
And the side effect, that TDM1 which you had, like, because our experience is a little more simpler with TDM1, but you said it was the toxicity. You've had a bad
Yes, sir.
experience.
Severe thrombocytopenia. Actually, I got 2-3 patients. 2 patients I gave. The 2 patients, both patients platelet count is come down to 20,000, 30,000 like this. I couldn't continue. One patient stopped after 3rd cycle. Another patient, I think 4th cycle, like the only 2 cycles only I gave. Means 2 patients only I gave. So both patients after 3rd cycle, 4th cycle, I discontinued. And one patient after 3rd cycle, the patients have progressed to brain metastasis.
Okay.
So now the patient is on trastuzumab plus lapatinib. I am putting now 2 cycles after RT, means after RT I am giving trastuzumab plus lapatinib. So like that.
Was it a generic or innovator?
Generic, sir. Both are generic.
Okay.
That's a question which we have to decide later. I think everyone has had experience with the generics. You know, the innovator is doing quite well. Anyway, we'll come to that later. Moving on. Okay, because I think our time limit is till 9 o'clock. Okay, we got half an hour. So I actually wanted to ask Nikhil also one more time. Nikhil, if the patient is not affordable for TDM1 and TDX, which I think around 80% of our population are going to be, what would be your next thing? Patient is taking trastuzumab and progressed. Your choice.
Yeah, generally, I'm comfortable giving lapatinib with capecitabine.
Okay.
Those on whom definitely chemo cannot be continued due to some other issues, we can, if they're able to continue with the trastuzumab also, I would continue trastuzumab plus lapatinib.
Okay. So for you, lapatinib cape over lapatinib trastuzumab if tolerable. Okay.
Yeah. I mean, ideally don't know whether we can comment which is better or not, but if tolerable, we have a little more stronger data for lapatinib plus capecitabine, so I would change to that.
Okay. I think, yeah, it's like, it's personal. Once you move beyond the second line, it's your own, every man for themselves. That's it. Okay, so the PFS of this Cleopatra regimen, this I'll ask Dr. Rona, is it as per your real world experience? Is the real world experience as per the trial? So the trial had 18 months of roughly PFS. So in the Cleopatra regimen, do you get 1.5 years on an average for most of your patients?
Most of the patients, yes, but there are exceptions. Some may have PFS more than 1.5 years and some may progress much earlier. That is my experience.
Okay. And Dr. Matthews, has anyone taken HER2 plus trans2 for 1.5 years in your setting?
No. That actually, generally, I didn't get that much PFS till now. Most of them have progressed before that.
Okay.
In
Dr.
fact,
Prashant? Yeah. Yes, Dr. Rona.
In fact, the longest PFS I got with this dual anti-HER2 blockade is 3.5 years. She's on this dual anti-HER2. She's initially treated with chemo plus dual anti-HER2. Now is on dual anti-HER2 alone.
Okay. That's what means. I think I'll take a opinion from Dr. Prashant as well. Your PFS, is Dr. Prashant there? Okay, I think we had an emergency. Yeah. Dr. Mithun, have you utilized this that long? Like
not that long. I think around 1 year is my average. The patients who have taken more than that, but average is around 1 year, I think.
1 year. So even my personal experience has not been that great. Patients have progressed probably around 6 to 1 year around. Because 1.5 years, I think so far, like the responses I've had with TDM1, I've not had with this regimen. So that will come to later, as in which is, what your experience is. And what is the goal of second line treatment for metastatic breast cancer patients? I think this is an outdated question. The goal is different for each patient. Some of them you have PFS, some of them you have OS. Some patients want quality of life. So I think it's very subjective unless somebody feels very strongly about this question, you can step in, but I think, all of them are very important. For each person, it's going to be different. Now, yeah, this is an important question. Would you like to reassess the patient for HER2 status? So you have this patient who progressed after probably 1.5 years. And after that, would you do a repeat biopsy in the metastatic site? So this one is a little, personal. It's your choice. There's no right or wrong answer. So I'll ask this first to Dr. Sanjo. Would you want to do a HER2 if this is having an accessible site and this is 18 months post this one? And I'll give you a second situation where a patient progressed after 5 months of therapy. You did the 3 months of therapy. Yeah.
So if it progressed very early, then I would have a doubt on the HER2 status. So I would ask for a biopsy. So, but if the patient progress after 18 months, then I may not ask for a biopsy. I would just change to say another line of treatment, HER2 based.
Okay. Dr. Ponraj, is it same after 18 months?
Two positive patients, I don't want to lose the options by doing biopsy. If it comes as negative, then again that two therapies may not use many. And of course, now the DDXT is there, but after 18 months, I may not do actually. Still get to.
Yeah, so I think this is a difficult question. See, the retest of HER2 positive patients. So as per some of the guidelines, they say that perhaps you can do a repeat HER2 test, means do a repeat testing. And as Dr. Sanju had said, if it's very early, definitely checking if it is actually HER2 is good, especially if you're using something like trastuzumab. But around 18 months, things are, little sketchy. There is some meta-analysis which says that there is a positive to negative conversion around 20%, and a negative becoming positive is around 10%. So normally for hormone positive tumors, most of us would definitely rebiopsy because you're avoiding chemo per se, and that's what around 1 year. But in my practice also, I do not rebiopsy usually, unless there's a patient who is very means if the cost of therapy is very high. Suppose we are considering TDM1, which we have a patient right now admitted. The thing is, I may consider rebiopsy when somebody is going to stretch their pockets to get this drug, because you can help make a decision. But again, this is highly subjective. Dr. Nikhil, any thoughts on that? Would you rebiopsy based on this?
No, it is highly, I think it's highly subjective, as you already mentioned.
Based
and every case, even in our own OPD, one patient, we may take a decision to rebiopsy. A similar profile of patient comes, we may, we may not biopsy due to a lot of logistics and practical consideration. I think if something we feel off, the tumor is behaving aggressively, as Sanjo mentioned, makes sense. Especially on we are sure about our therapy and the HER2 blockade that we are giving, and the disease progresses in a short time. It may be worth rebiopsying the metastatic site and looking at the tumor biology. Okay. Otherwise, I think a patient has progressed 1 year, at the end of 1 year on trastuzumab or trastuzumab plus pertuzumab, we'll continue with the next line of HER2 disease. Something which is not corresponding, then we can rebiopsy. So,
again, I don't middle here. If the patient had a complete response and later developing again metastasis, again deletion coming up, would you change? You get a biopsy done, or means just asking? Patient had a complete response, multiple liver mets on THP. The patient had a complete response, and after 1 year again having liver mets, then would you consider? Usually, I don't get. I don't do the liver biopsy. I don't do rebiopsy.
I still wouldn't. I wouldn't routinely. Main reason I don't do it is because we have other options. If it comes negative, we know tumor heterogeneity is there. We are not giving certain options to the patient. But if there is, as I said, this patient which I had to do because of the cost issue, they said if it's positive, they're willing to put in the money with some funding and all. So unfortunately, this patient had only bone metastasis, which progressed, and little some soft tissue. We did the biopsy, report came today. They said no tumor cells in the biopsy. So now I'm going to tell the patient, we're not going to repeat, they're going to go to TDM1. So these are the practical problems. So I think, as Ponraj said, it's better not to biopsy in this case.
I'll add a point, Arun.
Yes, sir.
I feel that there is a classic teaching is once you are HER2 positive, you are always taken as HER2 positive for lifelong.
True.
I don't know. That is what the teaching was during my residency time. If you are
So this
HER2
is-
negative,
yeah.
you have to biopsy and
HER2
see.
negative.
I just read this percentage for this thing only 21%. So you know,
Yeah.
it was
No,
surprising. I thought it would be less
positive
than
become
5%.
negative. I don't know. That means the heterogeneity factor is there. That is the correct
Negative
time.
becoming positive, Prashant.
Yes.
Negative becoming positive is there. Yes, you have to
Yes,
rebiopsy.
sir, here that any chance of becoming hormone positive, that means triple positive like that actually. Become is
Yeah.
too positive.
So that is the only thing why you have to do a
theoretical
biopsy. Konrad, you are
Yeah.
correct. So that is what I want to tell. That means the biopsy should be only to look for the estrogen progesterone status, not to decide
Yeah.
on HER2.
Yeah,
For
good
any-
issue. I think in practical, yeah, it's not that, you know, that we biopsy that often also. The hormone variations is much more common. The hormone positive becoming negative is also, you know, quite common, but HER2 is still something subjective. This data, I don't know what's going to be, you know, final, but yeah, as we said, tumor heterogeneity also. I think we'll move faster right now. Yeah, this one is the changing in status now. Has anyone had this change in status? Any issues, Dr. Rona? A change in this HER2 positivity?
2 years back, I would not have considered rebiopsy in HER2 positive patients, but of late I have seen discordances. Yes, HER2 positive become negative and negative becoming positive. Both, I mean, we have seen in both ways. So, in all cases, if it is biopsyable, I would prefer to do a repeat biopsy.
Okay. Okay, so I think we'll move on to the next question. Just give me 1 second. I've got a small. Yeah, sorry. Quite some time. Okay. So yeah, I think we'll move on faster. My family time is starting here. So back to the case. This patient, as we said, they received TDM1 after 1.5 years of Cleopatra protocol, and starting the TDM1, we have those randomized control trials. We have Amelia, which was beautifully, you know, described in detail by Dr. Arun. So we're just skipping past this. This is the what AstraZeneca is bringing out. This is the Destiny trials with the usage of trastuzumab deruxtecan. It's got very impressive numbers when you compare to TDM1, 28 months versus 6.8 months, a median overall survival not reached. So this trastuzumab deruxtecan, TDX, is jumping up the, you know, pile over here, and probably it may, as Dr. Nikhil predicts, it's going to enter the first line therapy. Now, after that, we did follow up this patient. After 7 months, what was seen is follow-up imaging was done. And after that, I think there was progression in this patient. So what is your duration of response with TDM1 on an average? So I'll just ask this to Dr. Matthews. Like, what is your duration of response that you have seen, like on an average? I think the trial had around 9 months or so, 8 months or so.
Average of 6 months.
Average of 6 months. And did you have any long-term responders?
Yeah. Right now, one that innovator, it's actually going on, and it's in the 3rd year now.
Okay. One more next question, Dr. Prashant. How many of your generics have long-term responders? Direct question.
I don't know. I don't know any answer offhand, but I think so. There are no much, probably.
Okay. So I think 2 patients I've used generic progression in 3 months, and long-term we have, you know, other patients get around 6 months, and, you know, who knows, you know, the experience is better with, you know, Capsula per se, I think, for most of us.
I have got one patient, or 12, means almost 9 months on generic.
On generic.
Having good
Okay.
response. Okay.
So, Trishur environment is definitely conducive. So we recommend, okay, take the generic there.
But
Next
4 other
question.
patients had progression on after phosphate.
Okay.
Generic.
So there will be that tumor biology working in favor in some of them. So anyway, I think that's the overall experience. Like in North India also, I've got my colleagues who, you know, same thing. They're complaining a lot about the generic. Okay, so this is another question. As Dr. Aruna described before, would receiving pertuzumab in first-line metastatic breast cancer impact treatment management? Now, again, as we saw, this one, there have been studies which said that if you receive pertuzumab, before, your response to TDM1 is not going to be that good. Dr. Mithun, any thoughts? Like, would that change your practice if the patient received Cleopatra? Would you not give TDM1 because there is some data saying that it is not that effective? Would it change your practice?
No, definitely if TDXT is available and if the patient is affordable, second line I would go for TDXT.
Okay, TDX per se. Nikhil, any difference?
Yeah, I think it makes sense what even Arun sir previously had discussed. The DDXT, you have that bystander effect also, so that also might be adding on to the additional benefit over TDM1 in the tumor. And if patient is, we know that there is definitely a decreased efficacy in a patient with an dual HER2 blockade upfront for TDM1. So TDXT would be the automatic choice if there is no restriction in logistics.
Otherwise, means if there's
TDXT,
still.
Otherwise, I think the choices are limited. If we would still consider TDM1 for whatever it is worth. TDS is not possible or not available, we'll give TDM1.
Okay.
They're not affording that. Lapatinib capecitabine.
So
I don't know whether lapatinib capecitabine will have a better effect than TDM1 in such a setting. I don't think so.
Then I'll ask a little difficult question to Dr. Prashant. Like, we have the Catherine trial where you have given, trastuzumab prior, and then after that switch to TDM1 if there was no path response. So that trial had very less pertuzumab exposure, maybe I think it's less than 20%. So would you, in a patient who received neoadjuvant pertuzumab, consider TDM1 if there's path response, if they have received pertuzumab? And I just went back and looked at that, the forest plot. So subgroup analysis, it's actually crossing 1. So it's not significant in patients who received prior HER2 therapy. So Dr. Prashant, would you not consider TDM1 in residual disease as per Catherine in a patient who received full doses of pertuzumab as neoadjuvant?
The question is whether I will give TDM1 if the patient is not in PATCR.
Not in PATCR and received pertuzumab.
Not in PATCR and adjuvant they have received, neoadjuvant they have received.
Neoadjuvant pertuzumab has been given.
No, but I will give TDM1.
Okay.
Because I am inclined for TDM1. Basically, even though this two has not worked, continuing the same thing may not make a benefit.
Yeah, I think it's a good point.
Other way around is, what I feel is, if you are starting to have a node positive and you are starting with the doublet, I feel that you should continue doublet, even though you don't, even if you achieve a PATCR.
Okay.
Even though they tell that you can de-escalate to trastuzumab, I felt you have done good in a doublet. So sometimes I push people that you have to continue with the doublet, even if you have achieved a PATCR.
In node positive patients.
In node positive, upfront. In a very small T2 N0, it's different, but otherwise.
Okay. Yeah, I think that's a good answer. Means there's no particular thing saying you cannot or may not use. The thing is, with this expensive medicine, there is also the not many options, and if you just ignore one of the options totally, I don't think you're valid. So still, I think the majority would still continue, using TDM1 in spite of this. So back to the case, this patient, as we said, progressed. And he progressed on TDM1, and on the progression was mainly in the brain, where you had brain metastasis. Also, the bone metastasis also had increased. So which treatment would you recommend in this patient? Like, once you have brain mets, would you recommend radiation, or would you recommend surgery to the brain? I think this is multiple brain mets, 3 lesions, okay, all less than 2 centimeters, or just change systemic therapy without radiation or surgery. The other patient is symptomatic. So I'll ask this Dr. Sanjo.
So there is progression with respect to brain as well as extracranial.
Extracranial, both progression.
So if there is an option of giving TDXD, then I would prefer to go ahead with TDXD.
Okay.
So, to take care of both systemic as well as so if the patient is symptomatic for the brain met, then maybe I would radiate the brain first and then continue, then change to TDXD. If the patient is not symptomatic for the brain mets, then I would irradiate the brain and then give TDXT.
Okay. What about surgery for the brain mets, which are there?
Multiple brain mets, is it?
Yeah,
Multiple.
3 of them. Multiple, yeah, depends on your definition of multiple. Because some radiation oncologists do not consider 3 as multiple.
3 as
SRS to 3 lesions have been up to, I think, even 10 lesions, you'll see. So would you consider surgery in this? It's small.
Not, still be radiation. Still
I think that's a, a valid distinct point. And this is to Dr. Punraj, like SRS versus WRT versus surgery. I think this is more of a radiation oncology question. But is there any particular thing like SRS in, single lesion, WBRT for multiple lesions, surgery for one lesion? Is that the way you?
I think surgery, I will not prefer. Actually, I will take it over the option of surgery. I think instead of that SRS versus WBRT, I think single lesion means SRS we can consider actually multiple lesions. Whole brain RT can be considered. Surgery, I think I may not consider for. I think that much of.
Suppose has read about Foundation 1 and everything, and they ask you like, sir, should we get material for Foundation 1? Would you tell it's HER2 positive? We don't need to do anything, or would you say, okay, fine? Would you want material and send a NGS panel at this juncture? You're because you're running out of options. You've come down to TDM1. TDX is not available. Would you consider in that case a surgery for material, or no, absolutely no surgery? A difficult question.
I think I will not prefer surgeries. I
think. Good. Yeah, should stick to it. So that's what I said. There's no right or wrong answer. Some patients specifically want something, some options which run out. So I think in the north, there's more surgeries happening where they take the material, send it for Foundation 1, and the justification is that okay, they've completed multiple lines. We have to think outside the box and things like that.
No, when patient becomes more intelligent than us, then better is to refer them.
But patient is customer is king. What they say, document, and then that's it. But yeah, that's it. Take a second opinion is always the other way. So this is practice what we do. If you have only brain metastasis, I think many of us would continue the same medicine, take care of their brain mets with radiation or perhaps surgery. Maybe in this case, I think surgery would be surgery followed by SRS. Some medical oncologists might be inclined, where you have a single brain met, rest all is responding to take it out and then, irradiate the cavity. So it's personalized per se. So you have some data where you can give up to 10. So I know of certain doctors in Mumbai who treat up to 20 brain mets, and they say proudly in the conferences also. So I think, does anyone have any experience of more than 20 brain lesions treated with SRS in their institutes? I think not. In Kerala, things are more.
And anybody will count like that 20s actually. I think more than 2, 3 will catch multiple only. I think 20 like that.
No, they count and they're proud of it also. So
I don't know. I think
people are proud of it. I've had these meetings, in Bombay. So they have given up to 20, and yeah, they say the patients are doing well also. So, as I said, again, it's your patient, it's your call, end of the day. Choice of systemic therapy in brain metastasis patients. So this is, again, I would ask this to Dr. Rona. Systemic brain metastasis, this is after everything, after TDM1. Probably would you've given radiation. There is systemic disease also, you want to cover the brain. Would you think of tucatinib in this case, or would you be
if tucatinib is available? Yeah, if tucatinib is available, you can consider. Otherwise, I'll go with lapatinib plus capecitabine.
Yeah. So yeah, I think the lapatinib capecitabine is the poor man's choice. The simpler choice. Pretty well used, and we have good responses. But yeah, there is data for tucatinib available. Tucatinib, capecitabine, and trastuzumab combination, which is there. And it's shown some overall survival benefit also in these patients with brain metastasis, as you can see the separation of the curves over here. Trastuzumab deruxtecan is the other one, which has also shown pretty good responses in these kind of patients. You have the Destiny 2 trials, which looked at, comparison after TDM1. And this had a lot of brain metastasis patients. And as you can see from the forest curves, it's done pretty well. This is a Canadian perspective where they've used Cleopatra protocol upfront, and if you had brain mets, they directly jumped to tucatinib. But I think most of us practice radiation followed by, if you have TDX, otherwise shift to TDM1. Probably because tucatinib availability is also not there. Once it's freely available, I think perhaps some of us might try this, regime. So anyway, this patient was started on trastuzumab deruxtecan because it was available over there, and she's doing pretty well, apparently, as per the last follow-up. So there are a large number of medicines which are available for HER2. So that's why I think, it's good to preserve the HER2 positivity as much as possible. And the sequence per se, we'll just run through everyone again, starting with Dr. Matthews this time, which is your preferred. Now here we have trastuzumab deruxtecan available. So just simple one-line answer: Cleopatra, deruxtecan, and TDM1, or the second one. First or second?
Go first one.
First one. Dr. Prashant, first or second?
First one.
First one. Dr. Mithun?
Yeah, same. I think first one.
Same. And Sanjo?
First one.
Okay, I think Punraj?
Same only, sir.
Okay.
But is there a point in giving TDM1 after TDXT?
That's a very good question. I think there is something, better than nothing, or you have to go for the worst one of them all, which I think is margetuximab or margetuximab, which I think had a 0.9 month survival benefit. So compared to that, there is some chemo conjugate. So I think I would still, give it before, shifting completely towards chemo per se, and or margetuximab if the patient understands, its benefit per se. So I think everyone agrees that transfer TDX is the future. It's going to be there. Now, only question is it going to enter first line? TDM1 failed in first line, but we don't know the comparison with TDX and TDM1, TDX are outperformed.
After TDXT be failing, then we can, instead of giving TDM1, we can directly go for lapatinib capecitabine like that. We don't give TDM1 HCR.
Okay.
Already patient is exposed to TDXT, then no point of giving TDM1. Instead of that, we can go other options, other TKs.
That's a good point. Yeah, that is definitely that. I think that would be more valid per se also. The thing is, this antibody outlasted everything. So as we mentioned before, continuation of things beyond progression might help as we continue trastuzumab also. So ideally, the trial should be TDM versus, supportive versus physician choice after TDX. So I think that will give us a perfect answer per se. And I think everyone said this line of therapy, if you had the chance, you would prefer it in the second line setting. The reason why is obviously because of the data. Any difference of opinion? And after your Cleopatra, we would consider trastuzumab deruxtecan. I think that's the unanimous decision as per AstraZeneca. I think that's what they want to hear. This is just all the survival outcomes of each trial and Destiny 1, 2, 3, all those grossly improved overall survival values you can see over there. So this drug is good. It's here to last. And yeah, this is the next question. As we discussed this also, TDX1. After that, Dr. Punraj would prefer lapatinib, capecitabine. Dr. Nikhil, TDX, would you give that margetuximab or LapCap or TDM1? 3 options.
Reading about margetuximab doesn't seem that this thing. I think I would stick to giving lapatinib or some tucatinib or some TK. Yeah, I would do a TK rather than continue with the TDM1.
And would you consider TDM1 anywhere along the line of treatment after TDX or never?
Maybe if the patient is still alive after all this, then we can consider. In fact, I might even consider trastuzumab and some other cytotoxic chemotherapy if the PS is preserved.
Okay, so alive. So PS4 is alive. Okay, so PS4 is still alive. So you will consider TDM1. Okay, but I think that's the thing. It's as long as what the patient wants. If they want to, they can take it. So I think that's the last question. We've ended hopefully on time before 9. Okay. Thank you to Bobbin sir and the AMPOK for this opportunity. Thank you to all the panelists for the wonderful discussion. And over to the organizers. Thank you.
Thank you. Thank you, Dr. Arun, for this very good moderation of the session. The practical issues which we all face in our day-to-day clinical practice when you're dealing with HER2 positive patients have been extensively discussed in this panel discussion. So even though we have the data, as I discussed prior to the panel discussion, when it comes to the practical affairs, it's a totally different ball game. So we may have to cut corners in many of the situations. So depending upon the financial situation and the availability of the drug, we may have to do all kinds of modifications are required. So all the practical issues were discussed, and I would like to thank all the panel members for actively taking part in this discussion. So thank you all. We'll catch up soon. I think next week we will be having our AMPOK academic postgraduate presentation will be there. So thank you all for once again for joining this session. And I would like to thank all the postgraduates and other delegates who joined the meeting. Then next, I would like to thank AstraZeneca for taking up this initiative for this presentation, as well as Indus and MQR for supporting this meeting. Thank you all. Good night.